And on that note, emergency providers are definitely becoming more and more skilled with point of care testing. Ultrasound has become, we call it the new stethoscope. I don't know if it's quite there, but using this point of care testing and using ultrasound at the bedside can give you a dynamic understanding of what's happening with your patient. So it can be used for source identification, for example, a right upper quadrant ultrasound to look at for biliary disease or cholecystitis. But it can also be used in your patients who are hypotensive with the rush exam. For anyone who's not familiar with the rush exam, you're basically looking for undifferentiated shock. In our case here with sepsis, we assume that it's a distributive shock. So often you might not see much with the pump, the heart. Sometimes it's hypercontractile, sometimes it's hypocontractile, but it also may depend on the state or the kind of progression. I think the most important aspect that ultrasound can be used is with looking for fluid status, looking at the tank. How does the IVC look? Is it normal? Is it small? Is it peritonitic? Is it showing signs that the patient would respond to more fluids? Would it show signs that the patient is already fluid overloaded and giving more fluids is not the next step to manage their blood pressure? So I think the ultrasound can give you a lot of information in these patients. Getting to monitoring. So vital signs go a long way, right? Our first step is to understand if the patient's in septic shock. The first step that we have, or the first kind of monitor or trigger that we have, is the blood pressure, right? So just monitoring changes in pressure, having one number doesn't always give us the full picture. And especially if your patients are sitting in the emergency department more than a few hours, we want to watch this over time and see how the patient is transitioning from one stage to the next. Monitoring urine output also gives you a good information about their fluid status. Like we talked about IVC monitoring with ultrasound, lactate levels and capillary refill or passive leg raise are other ways to look at tissue perfusion. Lactate levels are recommended as part of the Surviving Sepsis campaign. Following them for management or understanding how to adjust your fluid resuscitation is recommended if it's available. There's some studies that have showed that cap refill and passive leg raise have shown to allow for monitoring appropriately of sepsis patients. That has not shown worsening mortality outcomes, that these things are very easy to do at the bedside, and we're able to continuously monitor patients and how they're responding to this volume expansion. I think that in the ED, we don't always have all of the tests that we want, but we can always reassess our patient. Always coming back to the bedside, looking at the patient, looking at their vitals, and talking to them, doing another exam. Really goes a long way. In terms of actual internal monitoring, arterial lines are recommended. Once we get to a point where the patient does not seem to be responding to volume expansion or responding to the fluid boluses, norepinephrine is the first line recommended vasopressor for adults. Epinephrine is for first line for children. But these, again, shouldn't be delayed for a central line. Mortality rates in patients who are in ICUs or have hospital-acquired infections, it's much higher than patients who arrive with community-acquired sepsis. So being cautious about what kind of lines we're putting into patients and how they're going to be managed moving forward shouldn't be something that we do kind of at the whim, right? We want to make sure that our patients are fully resuscitated and that this is something they need. If a patient is septic, starting vasopressors through a peripheral IV is an adequate first step. You don't have to jump to a central line. Sometimes patients need source control and need pressors for an hour while they're waiting to go to the OR. And that is something that's fine to do through a peripheral line. As long as it's a temporary thing, you know the outcome, you know the endpoint for that. But starting vasopressors in patients who are no longer fluid responsive is the next recommended step. So recapping what in emergency medicine are really our priorities. It's identifying your patient from this pool of undifferentiated patients you have that come to your door sick every day. Making sure that we're doing timely initiatives, pulling cultures if we can, pulling lactate if we can, but not letting these things stand in the way of starting empiric antibiotics as soon as possible and starting IV fluids. Really using that individualized hemodynamic markers to guide your fluid resuscitation. Any point of care testing or repeat vital signs, repeat physical examination findings can go a long way in terms of monitoring your patients without needing to use extensive invasive monitoring or testing that isn't available in a timely manner for us. The emergency department really has become the safety net of the medical system. So I would be, I don't know if I could do a lecture without talking about the rest of the system. But besides our medical care, there's a lot of things that impact mortality of patients with sepsis. Some of these things I've learned through extensive literature reviews. There's a lot of information out there that's coming available now, now that we've identified this big gap in research. But there's a lot of opportunity for more research to be done in this area as well. But some of the biggest influences are delays in people seeking care. Someone once said, education is a vaccination for the public. And I think that public health, coming from the standpoint of a public health practitioner and understanding how far vaccinations can go, understanding how far education can go in a community, and helping people understand when they're developing a severe disease and should seek care, but also where to seek care, and understanding the things that stop them from seeking care in the most appropriate place to begin with. A lot of times it comes back to finances, to alternative care that's available in different environments, and then to education, health literacy. One of the studies that was highlighted in the World Sepsis Campaign was focused on the sepsis mortality in DRC, Sierra Leone, and Nigeria, which focused a lot or reported on some of the same findings that we found in Ghana this past year, that a lot of the system is set up in a way for patients to move through it in a stepwise manner. But sometimes that can also lead to delays and lead to inappropriate hospital care up front, or lack of resources, not allowing patients to get to the care they need in the time that they need it. One of the studies that came out of Brazil showed that transfers between hospitals led to higher mortality rates of patients with sepsis, but also ED boarding, how much time they spent in the emergency department when they had already been slotted to go to a ward or to an ICU. And then, of course, hospital-acquired infections and lack of resources. Like we'd seen previously, resources that don't allow you to achieve this bundle, whatever bundle you decide is appropriate for your setting, but being able to follow through with some of all of those steps is really kind of a opportunity, a critical aspect that's affecting mortality for these patients. And then the Surviving Sepsis Campaign guidelines are, like we said at the very beginning, are based on high-income country and ICU settings mostly. So I think our next steps moving forward from here are to figure out what guidelines and what bundles really should be and can affect mortality in each of our own individual practice settings, because it matters. It's not all the same, and it really can have a big impact on patients. But I think our next step is to figure out what our new bundles should look like. Well, thank you. I appreciate you guys letting me chat on for so long. Love to take some questions on emergency care and health system development. So yeah.
Thank you, Dr. Lukacs. That was brilliant. Thank you so much for giving this talk, clearly from an expert in the field. Sepsis is a medical emergency. You have worked in the setting that transpires. I'm just going to say a few words, but I'm inviting everyone to ask questions. Either raise your hand or maybe put it to the chat. I have one question in the chat that I'm going to read soon. But Dr. Lukacs, I'm just so happy for some of the quotes that you just gave me. I mean, I really like the if you don't think of it, you won't recognize it. I think that's what you said. I think that's like true, just true. That if you don't think of sepsis, you won't get there. You won't see it. And this is one of the big targets of this lecture series as well, that we sort of raise the awareness around sepsis, raise the awareness of the medical emergency that sepsis is, the dangers that it poses to our patients. I'm really hoping that we're also going to be able to, preach beyond the converted, and then please spread the word about these sessions. One thing, because the question was in the chat, we will be recording, or we are recording this session. We will be recording all sessions, and we will make them like freely available on our website, and also on our YouTube channel, and also AFM is going to link to that. So don't worry, you will be able to look at these sessions again, and also share them with others. Another one that I really liked is the vital signs go a long way. It is true. I mean, you've told us that only 1.5% of African hospitals, there's a study saying that 1.5% of African hospitals have the physical equipment and resources freely available to do all the steps that the Surviving Sepsis campaign lays out in terms of 1 hour bundle. And of course, we are very aware of those limitations, but there are things that we can do. We vital signs monitoring, using our clinical knowledge, because that's something that we all have available, all of us, clinical knowledge, clinical experience. So to monitor our patients and look at our patients. And, the third one that I liked, ask questions. The more questions you ask, the less diagnostics you'll actually need. So I really like that one. Let me I'm sorry, I'm talking a lot. Let me just stop and go back to the questions from the chat. There was one question from Ethiopia, which is sort of going back to the fluid management. So in case that hypotension doesn't improve, maybe you could reiterate again what to do if in case it doesn't improve the hypertension. Do we need to go to vasopressors regardless of how the patient responds to crystalloids?
So yes and no. I think the first thing you need to do is reassess your patient, right? You give a bolus, you see what happens. If they start to improve, maybe they need another small bolus, and you step up from there, give another small bolus, and then reassess again. Right? Even that's just a set of vital signs, looking at their IVC with the ultrasound, looking at their capillary refill, doing a passive leg raise, and seeing how they're responding and what their individual comorbidities are. If that's now that they're becoming fluid overloaded as you're giving more fluids, maybe you'd stop. If they're still hypotensive at that point, the recommendation is to start vasopressors. But this should be done cautiously still, right? Starting peripheral vasopressors is recommended to support their hemodynamics and their microvasculature, as well as their macrovascular changes that are going on just within the peripheral circulation, but also their central circulation, supporting their heart, pushing them to improve perfusion, right? The end game is to increased perfusion to your organs. If they need a vasopressor, starting it peripherally and starting it as soon as you recognize that they're no longer responsive to IV fluids or to crystalloids is recommended, but then taking that opportunity while they're getting, hopefully through a large bore IV in their arm, taking that opportunity to cleanly set a line, to follow all of your sterile technique, to put in a central line for them to continue getting the support they need in a safe way. So I think there's a handful of things that need to be time intensive and need to be done as soon as you recognize the patient's not fluid responsive and they're still in shock. Starting vasopressors right away, starting antibiotics right away, but then taking the opportunity that those empiric antibiotics and that vasopressor support through a peripheral line give you to do things safely, to continue evaluating and finding the source, to do source control, to figuring out where exactly their infection is and tailoring your antibiotics to your local epidemiology, and then to setting lines and to doing things as safely as possible. So we're not causing that in-hospital infections that have such a higher mortality rate. So yes, but I would say, look at your patient, see what they need, talk to them, talk to their vital signs, see how they're responding, and tailor it from there.
Yes, thank you. Thank you for that answer. Let me just go through the other questions. There's one from Nancy. Nancy's an emergency nurse working at an emergency department in Kenya. And this is maybe going back to the systems issues that you mentioned. Nancy tells us that most patients that present to the ED where she works come late. So they come too late to the referral hospital. So the outcome is, and she says, always poor, as well as the ICUs that are always full. So they really try to give their best. What is you talked about the health system. Do you have any solutions or any ideas, anything that you know of, any, research or projects that have helped to sort of decrease delays between facilities and institutions?
Yeah. So this is like 8 questions in one.
I'm sorry.
This is a fantastic, this is the problem, right? This is the root of it. And there isn't a simple solution. Some research has been done into these areas to elucidate what is influencing people coming late. It's finances, it's distance, it's health system design, it's transportation, it's family support, it's social financial support. And then it's recognition by the community that there's a problem. For somebody to recognize themselves, usually what's been found is that patients recognize they need to go to a hospital when their disease is bad. Otherwise, they try other things at home. They're trying other options and trying to seek care other places. But until they become really sick where they can't take care of themselves, a lot of people don't bother coming to the hospital yet. So that's not necessarily something that you as an emergency nurse in your day-to-day shift are going to be able to influence. Other things that are also out of our control are ICU beds. Boarding in the ED is a huge problem everywhere, and it's affecting outcomes. It's affecting patient mortality rates. It's affecting patients with sepsis and shock and severe disease from getting the time-intensive care that they need. But I think in this moment, the best advice I have for you is to keep going. That each patient you see on your shifts individually, you're making a difference for them. And even if it seems hopeless and it seems like every single patient has a poor outcome, there are a few you're affecting, and you need to hold on to those personally and emotionally to make sure that you realize what a powerful effect you as an emergency nurse are having on that person's life. So don't give up. Even if it seems that every patient is having these poor outcomes, do what you know to do best, right? Monitor your patients, make sure you're identifying if they're becoming more sick and need to escalate care, need to take priority and need more attention. Get them the care they need as soon as you can, whatever that means to you in your setting. But don't give up. And let's do more research and, get to the bottom of some of these.
Yes, exactly. I definitely second the don't give up. I think that's what we do every day, right? All of us, and we have to. Let me just go through some more of the questions that came here. There's one about you talked about blood cultures, right? About taking blood cultures is one of the steps of the 1 hour bundle, and we have a question from Mary, who is a clinical microbiologist, and she's just wondering, this is meant to be like a little bit of a knowledge exchange as well, and she was just wondering, do you happen to know blood culture positivity rate in your setting? Do you have any figures for your hospital?
Offhand, I don't know them. I could definitely find out.
Yeah.
This also is part of the monitoring that's important, and part of maybe not our 1 hour bundles that we're measuring the ED, but part of quality assessment and monitoring patients to see are we getting positive cultures? Is every patient who comes in with a severe infection becoming bacteremic? Is the cultures that we're getting, are they positive from real infections, or are they skin contaminant? Are we doing a good job collecting those things? Is it helping manage clinically? But often we're getting those preliminary cultures back within 24 hours, but they can take up to 5 days to get final results. So most of the time I'm not the clinician primarily managing the patient at that point when we get them back. So I could definitely get some information and would love to share. But it's not often something I'm managing in the ED.
Right. Right. Yeah, that's totally understandable. As turnover times for the cultures are also like in our settings as well, like 2-3 days. While we might be able to get some information within a day, if it's gram positive, gram negative, something like that. That it's still 3 to 4 to 5 days, and I'm an ICU physician, so I'm more used to dealing with the results of cultures, and I can tell you from here that actually positivity rate here is like something around maybe 10%. So there's a lot of diagnostic that is going to turn out negative, and then we're not going to know. Of course, at that point, we hopefully already have started empiric treatment and saved our patient. But I'm just saying that, the most important thing about blood cultures is that you take them. You actually have to do some diagnostics to, like, further down the line, be able to de-escalate. And that's, maybe a follow-up question from Mary. And, Mary, sorry, but after that, I'm going to switch to somebody else. But you were asking if the results delay up to 5 days, which they sometimes do we de-escalate or continue with empirical treatment? As I say, I'm from intensive care, and, it very much depends on your patient and on the clinical course. We usually de-escalate once we know the culprit. So once we know that we're too broad, we sort of de-escalate. Of course, we need the results of the cultures for that. We do have a very good, sort of open line of communication to our lab. So I think that's something that can be done at least, later on after the emergency department in the ICU, to sort of have like a regular sort of exchange with the microbiologist to maybe ask them if they are able to give you some preliminary information. But yeah, we do de-escalate, and that's part of the recommendations of the Surviving Sepsis campaign. Usually, once we have the results, but it depends on your patient. So when you see that your patient is actually improving, or if the other way around, if you see that the patient is not improving, then this will probably cause you to think about your microbiology, about your antibiotics, and not de-escalate too early. But once you see that the patient is improving, plus you maybe or maybe not have a culture result that allows for it, you do de-escalate. We're going to touch on, issues like antimicrobial resistance in other sessions. We will be having a clinical microbiologist from the STAIRS network talk about AMR. And about diagnostics. So please bear with us and come to the other sessions about this. Let's maybe stick to emergency care, and maybe one last question, since it's already almost in my setting 6 p.m. Maybe just for wrap up, one more clinical question. And this is again going back to sort of assessing the fluid response. Dr. Lukacs, what parameter do you recommend to assess the response to resuscitation, fluid resuscitation, in a setting with no access to arterial lines or advanced sort of ultrasounds? And what cutoff do you personally use? What's your sort of personal protocol?
I usually go with capillary refill as my first step. I think the skin exam can go a long way into knowing if the patient's diaphoretic, how their microvasculature is responding to these macrovasculature changes that we're making. But there's a lot of research on passive leg raise. Read more specifics. I saw a question about what exact parameters to use. And I would just look at the primary studies to see, what specifically without ultrasound. But it's never in a bubble, right? There's never one thing. You never de-escalate antibiotics based off of a negative culture alone. You never base all of your fluid resuscitation on one number alone. It's taking a whole picture of the patient and all of the information you can get from them to put it together as a big picture. To understand what's going on with their patients, because they're complex, right? Nobody fits in one little box. Nobody responds to one thing. So putting it all together is important, and taking the whole picture.
Right. Look at your patient.